My name is Kara Richardson, and I did my program on identifying and treating ICU delirium. I currently work at C3 ICU at Lakeland Regional, and this is an issue that we see in a lot of our patients. There's been a lot of research done in the last decade on understanding delirium and also the different treatment modalities to help ensure that patients are able to recover from this disease. So delirium is a brain dysfunction that's characterized by altered levels of consciousness. There's different types of delirium, and a lot of nurses don't really understand when they're assessing patients necessarily if they have delirium or not. Most patients assume that if you're delirious, you're going to be in hyperactive delirium, which is more seen with patients that are really confused, restless, agitated, very emotional. But the majority of patients that are actually delirious are hypoactive delirium, which means usually they're like lethargic, they have decreased responsiveness, they're withdrawn, they're apathetic. There are some people that have what's considered mixed delirium, which is just like they're super labile between being hypoactive delirium and hyperactive delirium. But because of the difference in responsiveness between different patients, it's really hard to pin down exactly if they're delirious or not, which makes it very confusing for nurses that aren't educated well to really decide whether or not a patient's delirious so that they can pass out of the doctor and receive treatment for that patient. So there's been some assessment tools created so that we can be able to identify delirium more effectively. In the ICU that I work at, we use the CAM assessment, which is the confusion assessment method for the ICU. And we do this once a shift at least, or if there's any change in the patient's responsiveness. So basically you start out if the patient has any change, like any new changes in their mental status, then you're going to continue on to the next step. If not, then they're obviously negative. This one I think is a really good assessment for the ICU because you're able to do it without a patient being able to speak. So if the patient is intubated, it's much easier to be able to do this. The next step is you check for inattention, which this is usually the harder part on other assessments like the intensive care delirium screening checklist, because those are all things that they have to answer verbally, whereas this is something that you can do with somebody who isn't able to talk. So you'll have them squeeze your hand whenever you say the letter A. If they squeeze whenever you don't say the letter A, so like on a different letter, or if they don't squeeze on the times when you say the letter A, then they'll get an error. So if they get more than 2 errors, then you go to the next step. So there's a couple standardized words that they use. Save a heart is one. They've also say Casablanca or a bad day. So with those standardized responses, that way we're able to have a good assessment over multiple nurses. So there's no changing and fluctuation in the patient's response. There's also some letters and pictures that can be used. Normally, most of our patients are able to respond with squeezing your hand. The next thing, if they have more than 2 errors, then you continue to go on and you see what their RASS score is, their sedation and agitation score. And if that's more than 0, or less than 0 even, like if they're more sedated or if they're more agitated, then they're going to be positive. If their RASS is 0, then you continue on to the next step. The next step is asking them questions to see how well their cognition is. So you ask them things like, will a stone float on water? Does 1 pound weigh more than 2? Obviously, if they answer those questions wrong, then they're positive, they're delirious. And then if they're not able to answer questions, like if they are intubated, then you have them hold up a couple fingers on one hand and then have them do it on the other hand. If they're not able to do that with both hands, then they're delirious. So I think the CAM assessment is a very good assessment for the ICU just because it's, like I said, you can use it over all types of patients, even if they're not able to speak. The assessment tool that's another assessment tool that's been used is the intensive care delirium screening checklist, which I'm not very, I don't know much about it, but it basically, you're testing all the same things. You're checking to see if they have an attention, if they're disoriented. You also ask if they're having hallucinations or delusions. You just check for like if there's any agitation, any inappropriateness of their speech, if there's any changes in their sleep and wake cycle, and then basically if they have labile responses, like emotional responses, which is what you would consider somebody to be in mixed delirium. So, with all the treatments or all the stuff that we've learned about ICU delirium, they've learned not a whole lot about what is an actual good treatment. The majority of doctors that were asked about treating delirium said that Haldol is the go-to treatment. And that was what I was taught in school and also in my classes here at the hospital. It says more than 80% of doctors believe that Haldol is the go-to treatment, but there's really not a whole lot of studies that have shown that that is true. There's been a lot of studies done to try and figure out what is the most appropriate treatments, and Haldol is still considered to be a good treatment. But obviously, if we can prevent it, that's really the best thing that we can do. Another medication that they look at is benzos, so like your Versed, lorazepam, things like that, in treating delirium, which usually those cause like sedation, but they've also been shown to cause more confusion and more incidents of delirium in the long run. The most promising medication at this point is dexmedetomidine, which is Precedex, and there's been a lot of studies done recently on whether or not that does well in treating delirium. It works very similarly to a benzodiazepine, but it has less side effects. The most prominent side effect is it usually will affect your blood pressure or your heart rate. So there's a lot of times that we'll be giving it to patients and it can affect that, so that we have to end up stopping the treatment because of that. Along with all the research on these medications, there's also been some experimental research done on medications that they believe that will affect the root cause of delirium. One really interesting study that I saw that was recently done was statin medications. So they were trying to see if cholesterol medications, since they treat the neuroinflammatory changes that occur from oxidative changes that most critically ill patients have. So like you're going to see that in patients that have sepsis, which is a lot of our patients. They were trying to see if that would have any effect. It didn't really have positive results. There were some patients that seemed to have some effects, but some that didn't. So they couldn't really make like a sure diagnosis that it was helpful. But it's interesting to see that they're looking at different medications and how they can be treating the root cause. Another medication or group of medications that have been shown to be helpful is the atypical antipsychotics, as those usually help with like the neurotransmitter imbalances that most physicians believe causes the delirium. So in order to have standardization among all ICUs, there was a bundle created to treat delirium, and it also helps to identify the issues that cause it and prevent it. So a big push in the ICUs right now is treating pain, making sure that patients' pain is under control. Doctors even want us to give pain medication before we give sedation to patients that are intubated. I've had patients that even when they say they're not in pain, the doctor still wants us to give pain medications first and see if that helps their agitation. So if we can, their thought is if we can control their pain, they can be more relaxed, and that's going to keep them from having abnormal cognition. Another thing that we do for patients specifically that are on the ventilator is we do a daily spontaneous awakening and spontaneous breathing trial. The spontaneous awakening is we turn off all the sedation. Depending on the patient, you may leave on their pain medications or not, and you turn off all their sedation and see how they do waking up. So usually you'll give them at least 30-45 minutes to wake up. Sometimes they'll be agitated, so you'll kind of just sit in there, try to reorient them, see if they can wake up enough to where you can keep the sedation off. If they're really agitated, then you restart the sedation, but you restarted at half the dose of what they were running at prior. So this is a hope to decrease the amount of sedation that we're giving patients. Once the patient is done with their spontaneous awakening and their sedation is off or greatly decreased, then you're going to do your spontaneous breathing trial, which is when you put your ventilator to the CPAP setting. So the patient is forced to breathe on their own, but you give them the extra pressure and the oxygen that they need to hopefully encourage them to breathe well. And as long as the patient's doing well in their spontaneous breathing trial, then we're more assured that they're going to do well when we try to extubate the patient. Another thing that they do is the sedation. They think it's really important to have the choice of correct sedation and choice of correct analgesia as well. It's mainly for sedation. But basically we want to have the patients on the least amount of sedation that we can, and we prefer to give them medications that are shorter acting, so like propofol, because that can be turned off and the medication effects wear off very quickly, or Practicum, because even though that one has a longer half-life and so it takes longer for it to get out of their system, it doesn't have any respiratory depression along with it. So that is a medication that we can wean them off their CPAP and extubate them and still keep them on the Practicum as sedation even after they're extubated if they're still needing sedation. The next part is the delirium monitoring, which is like what I talked about previously, the CAM assessment or the ICU delirium screening checklist, and just being sure that we are monitoring patients at least once a shift, and then anytime the patient has any major change in their alertness or anything like that, so that we can promptly see that the patient is delirious and begin treatment right away to hopefully lessen the length of time that they're already in delirium. And the most unused part of the bundle is the early mobilization. Most nurses are really terrified of getting a patient out of bed when they're on the ventilator because of all the risks involved. There's a chance that when they get up, they could fall and they could dislodge their ventilator, or if they're in the chair, then they might try to get up on their own and they could hurt themselves or once again dislodge the ventilator. But really it's a stepwise action that's done to try and prevent or greatly decrease the chance of them having ill effects of mobilization. So usually the first step is you have the patient sit up in the chair, in the bed, so the cardiac chair, to see how their trunk control is, if they're able to sit up well and don't get too agitated and aren't trying to like get out of bed and everything, then you can have them sit on the side of the bed and dangle their feet off. That's another way you can monitor to see how they do with their trunk control, if they're going to be strong enough to stand up. The next thing would be you would stand them at the side of the bed, not going anywhere. You could do like some marching in place just to see how strong their legs are. Then you can do a transfer. So you would, instead of actually taking steps, basically they would just kind of pivot and sit into the chair. And then the next step would be actual ambulation. A lot of our patients that are in the ICU who are on the ventilator are already having issues with mobilization prior to being intubated. So that is one reason that we're not able to do it as well, along with just the fear. But it really does show to be very helpful in preventing delirium. And along with preventing delirium, it shows to help decrease the amount of rehabilitation that a patient needs after being released from the ICU. People that aren't mobilized can lose up to 40% of their muscle tone just in the first week alone of being in the ICU. And a lot of our patients are here in the ICU for several weeks on the ventilator. So it's almost necessary that every patient goes and gets physical therapy, goes to rehab after they go out of the ICU. So we're really doing our patients a disservice by not ensuring that they have all the help that they need to prevent further complications down the road. Another part of the bundle that was added later that is sometimes seen and sometimes not is F, which is family, and that's the family involvement. So you can give your patient's family different things to do, like tasks. So like with bathing, you can make sure your family is wiping down your patient's hands because that's going to decrease infection, or have them orienting the patient. So whenever they're in there talking to the patient and telling them what's going on at home and things like that, so that they still are being reminded of what's really happening in real life, so that hopefully you can decrease the amount of hallucinations and delusions and confusion that they have. So the main issues that we have with implementing and like treatments for delirium are lack of research. We still have a lot of things that we need to do to understand delirium. We don't understand necessarily all the things that cause it, or the medications and things that we need to be able to treat it effectively, as well as if there's more measures that need to be done that can prevent it, how we can basically protect our patients from getting delirium. We also, a lot of nurses, like I said, don't have adequate assessment skills as far as assessing a patient, whether they are delirious or not, and understanding if they're hypoactive delirium, hyperactive delirium, or mixed delirium. The treatments as far as those don't change, but it is very hard to notice a patient that's hypoactive delirium, especially if they're already sedated because they're on the ventilator. And sometimes, I mean, honestly, nurses look at it as, well, it's a good thing my patient is relaxed, but they're not like paying close enough attention or being really diligent in using their assessment skills to ensure that they know whether or not the patient is delirious. And then there's just inconsistency in the different preventative effects, as well as like treatments and assessments. So like I already said, the assessment issues, but some patients, whenever they're on the ventilator, they don't necessarily do the spontaneous awakening trial the way that they're supposed to do it, or they may not assess the patient correctly, or they may not be just reorienting their patient consistently. I try to make sure that every time I go in my patient's room, I tell them the time of day it is, what like actual time it is, the date, and who I am, especially if I think that they are delirious, because sometimes you can just look in their eyes and see that they really are not kind of sure what's going on. And I mean, there are times that you try and do all of these things, and even still, a patient becomes delirious. And I mean, there are people that are just more likely to become delirious. People that have issues with alcohol abuse or drug abuse or liver issues, people that already have impaired cognition prior to admission to the hospital, these patients are just going to be more likely to get delirium, and there's not a whole lot that we can do about it. But if we're more consistent in all of our assessments and treatments, then our patients will have far better outcomes. So that is